Record to the cloud. Okay, welcome everyone to PTSD in the older adult with Nirmala. Just to go over a few of our housekeeping things, we ask you to mute your mic, utilize the chat for questions and comments. We'll have some time at the end for anything, and then slides are going to be available to you. So you'll get all of the slides. We record this and it's posted to our YouTube channel. So you'll have access to the recording later on. To receive the 2 CEUs, you do need to have live attendance. So we will be monitoring that, and we will send out the CEU certificate and survey to the people who are eligible based on their live attendance. You will need to complete that survey to get the CEU, but if you do not need CEUs, you can get a certificate of attendance by completing the PSU survey that will go out as well about today's training. And all of this will be sent out to you within the next 2 weeks. Give us a little bit of time, and Nirmala has a lot of great additional resources that we will be sending along as well. Okay, so the people that are bringing you this, we are the Oregon Older Adult Behavioral Health Initiative. We were started in 2015, and we work to improve timely access to care from qualified providers and those who support older adults to provide coordinated, quality, and culturally responsive behavioral health and wellness services. We have 24 specialists across the state, and we do lots of collaborations and coordination. We build knowledge capacity through workforce development training, such as this one. And then we do community education, and we provide complex care consultations. So if you do not know who your county's behavioral health specialist is, please reach out to us or go to our website, oregonbhi.org, and you can find out exactly who your older adult specialist is. Okay, we do have an upcoming training at the end of June, and we're doing mental health advanced directives with Nirmala and Dr. Andrea Avia from the Oregon State Hospital. So if you're wondering about what that Declaration of Mental Health Treatment form is all about, and understanding the history of mental health advanced directives, it'll be a really great training. Okay, so we want to get started by introducing Nirmala. Nirmala is a licensed clinical social worker with a master's degree in social work from the Brown School of Social Work at Washington University in St. Louis, Missouri, and Bombay University in India. She is mission-driven with a passion for working with the most vulnerable clients, often addressing complex cross-sector care needs. With 36 years of experience in all aspects of behavioral health programs in the public sector across Missouri, New Jersey, and Oregon. Nirmala currently serves as a senior policy analyst and the older adult behavioral health lead strategist for the Oregon Health Authority's Division of Behavioral Health. In this role, she is the project director of the Older Adult Behavioral Health Initiative, the PASRR Level II Coordinator, and a subject matter expert for her division. She also champions the Project ECHO Geriatric Behavioral Health Initiative at the OHA. Nirmala recently played a key role in funding and establishing the Center for Excellence for Behavioral Health and Aging at Portland State University, OHSU, where she continues to be an active thought partner. So prior to her tenure at OHA, she spent 18 years with the Clackamas County Behavioral Health, including 10 years as a geriatric mental health specialist. Nirmala brings her strong social work and faith values to her work, emphasizing an anti-oppressive practices and the dignity and respect for all individuals served. Her career has been dedicated to the values of social justice and equity, with a particular focus on disability justice for individuals with serious mental illness. And she has delivered trainings on various topics locally and nationally over the past 20 years and enjoys coaching and mentoring new clinicians. Her professional interests includes healthy aging, social justice, workforce development, quality improvement, health metrics, bioethics, the intersection of law and mental health, and service delivery innovations. So we love having Nirmala as our person, our trainer, and we have a few poll questions that we would like you to answer before we hand the mic over to Nirmala. Okay. So here we go. So if you all would please go ahead, and we'll take just a few minutes to answer these questions so that Nirmala has a good idea of what your experience and who you are. And then Nirmala, I hand it over to you.
Can you send it out again for those of us who didn't scroll down?
Nirmala's muted. We need to take Nirmala off mute.
Yeah, Nirmala, you're muted, and I cannot send it out again. So,
can you hear me now?
Yeah.
Yes.
Okay. Angela Franklin, I was letting you know that once you conclude the poll, could you please just display the results, and I will go over them very quickly. And I was just telling the audience that there are 4 questions, so you need to kind of scroll down to complete all 4.
You don't get penalized if you don't. No worries. It just won't let you submit, or you shouldn't be able to submit.
So, Angela, do you think we should go ahead and end it? Okay, so I'm going to, can you all hear me? Hello, can you hear me?
Yes, we can hear you.
Yes,
okay.
You're good.
So I'm looking at who's in the audience. It looks like the biggest group is case managers, followed by QMHAs, QMHPs. We have social workers, we have skills trainers. Very happy to see community health workers. We have some APS folks. So a very nice mix. There are some supervisors and managers and some others. The next question was, do you work with clients who experience trauma? And guess what? 95% of you said, yes, we do. So you're obviously at the right training today. Does your workplace provide trauma-informed care? 90% say that your workplace or organization is trauma-informed. And then within the last 12 months, have you taken a training on this topic? And about the majority, 62% have not. And there was one question that I had asked, maybe, I sent it later, we didn't get put in, and it is something that just for you all to reflect on. How many of you who said you'll work with, 95% of clients feel confident in your skill level in terms of having knowledge about PTSD best practice and working with someone with trauma? And that's really a question for you to reflect on. So next slide. And I know I have a lot to cover, so I'm not going to go over every slide. You will get my slide deck, and here's my acknowledgement for most of the material that I've gotten for this training. And next slide. And my learning objectives are pretty simple. What is trauma and post-traumatic stress disorder? That you have a better understanding of the symptoms. You appreciate the lived experience of PTSD, especially perhaps as it as it manifests itself in people who are aging. And then what are some knowledge and skills that you need? One is knowledge about what are best practices, and then some kind of basic skills that you can use right away with your clients or consumers. Next slide. So let's begin with this. Imagine this. Imagine going through a traumatic experience like a car accident, an earthquake, war or conflict, or constant explosions. Think about it for a minute. That would be bad enough, wouldn't it? Just look at these pictures. Next slide. Now imagine reliving that experience over and over again, each day, like a terrible nightmare. And by the way, that happens to many people around the world, where they relive those devastating, horrific experiences over and over again. And some of those people go on to develop post-traumatic stress disorder. PTSD is viewed as a disorder of extinction. Fear and anxiety are a normal response to trauma, for any of us. For the majority of people, that fear will extinguish over time. We always talk about time being a healer. But for a minority of people, that doesn't happen. That fear doesn't extinct. And that remains alive and they experience it as though it is happening again over and over again. So imagine that. Next slide. So just a brief history, and I'm not going to spend too much time. Historically, PTSD was known as like shell shock in World War I. The mention of this disorder first came out in the Lancet, which is a British peer-reviewed journal, with soldiers documented as having various symptoms affecting their nervous system. I don't know how many of you are students of history, but World War I was horrific, especially in Europe, in terms of the kind of warfare they did. There are some great movies that have come out recently. It was trench warfare. It was horrific. And, most people were conscripted. So it was very young soldiers. And then in World War II, it began to be called as combat fatigue, and believed to be related to long deployments. That means you're out in combat on the front lines for very long periods and you get fatigued. So really there was no vocab. This was the vocabulary. The term PTSD has since then become a household name, and it first appeared in 1980. So prior to 1980, there was no term like PTSD. It appeared in 1980 in the third edition of DSM, the Diagnostic and Statistical Manual of Mental Disorders. And in the collective mind, this diagnosis at that time was associated with the legacy of the Vietnam War. So remember earlier, I told you the terms used were soldier's heart, shell shock, war neurosis, combat fatigue. After Vietnam, again, a horrific war. If any of you, again, are students of history, you know what it was to be on the front lines in Vietnam. And again, these were young men who were conscripted. That's what really gave birth to the name for this disorder. That was kind of the historical backdrop. Next slide. So what's the prevalence of post-traumatic stress disorder? And I'm talking among all adults. Based on diagnostic interview data from the National Comorbidity Survey replication, a past year prevalence for adults 18 and older was about 3.6% of US adults had experienced PTSD. By the way, that 3.6 is pretty high, because that's the same amount when you combine schizophrenia and bipolar disorder. It's around 3 or 4%. So 3.6% of US adults experience PTSD. And past year prevalence among adults was higher for women than for men. So there's a gender difference. So women were higher than males in this study. And the lifetime prevalence is about almost 7% for PTSD. Next slide. And so here again, this is data from 21 to 23, same survey, and you can look by age and gender. What is startling, you can see for gender, there's a real gender difference, correct? Women and men. And then you can look by age. The group with the highest kind of is age 45 to 59, and then 60 plus. So this is for looking, this is what that data, the data that I spoke about earlier. Next slide. And this is how the severity of it among that group of people who experience it. As you can see, it's kind of almost the mild and moderate are about the same, and serious is almost 37%. So the majority of these folks experience serious symptoms of PTSD, which are extremely disabling. Next slide. So what is the psychiatric comorbidity? Means what are co-occurring psychiatric diagnoses along with PTSD? Comorbidity was a very frequent occurrence, and we were talking about it just before we opened the doors for all of you to come in with the Southern Oregon team, that it is very frequent. So co-occurring or comorbidity was very frequent, almost reaching 80%. So we should expect it as the rule rather than the exception. That means you will have another psychiatric diagnosis. Major depression was the most common condition. And if you had major depression, it actually increased your symptoms of PTSD. So almost 54% had major depression. Anxiety disorders, social phobia was the most frequent, followed by general anxiety disorder, panic disorder, all of that. Substance use disorders were also common. The presence of psychotic symptoms was particularly significant, with over 30% prevalence in PTSD. There was a national sample they looked at that 1/4 of people with PTSD also met criteria for borderline personality disorder. And the other way around, people with borderline personality disorder met a lifetime criteria for PTSD. So in view of the impact of comorbidities on PTSD, chronicity, and functional impairment, early detection and treatment for both co-occurring disorders is critical and best practice. How many of you screen for comorbidities? We were talking earlier, that some complex case, there was substance abuse, there was depression, there was PTSD. You should be screening for all and treating them concurrently. Otherwise, each disorder symptoms are worse if they're untreated. Next slide, please. And here, I'm going to let you take a look at it, but you can see how frequently and why, borderline personality disorder, what's the kind of a difference. You can see this is a nice Venn diagram, that the intersection is where you see this blend, between the two. So what is the blend? Emotional dysregulation, self-destructive behavior, self-harm, suicidal ideation, dissociation and paranoia, negative self-image, feelings of emptiness, sense of numbness, sense of hopelessness. That is the overlap between these two. And that sometimes it can also lead to a misdiagnosis. Next slide. So what about trauma in older adults? According to the National Center on PTSD, 70 to 90% of older adults age 65, you may want to say almost all, have been exposed to at least one potentially traumatic event during their lifetime. Although many older adults do not meet full criteria for PTSD, about 7 to 15% of adults exhibit subclinical levels of PTSD, which on older adults can have a profound impact on their well-being and functioning. So the take-home message is 79 to 90% of older adults have experienced a trauma and been exposed to potentially at least one traumatic event in their lifetime. Next slide. And then what's some of the differences? What's kind of hidden in this older population? PTSD, I told you, was not an official diagnosis till 1980. So prior to that, there was no language to describe it. So that whole cohort is kind of lost. And when we're asking older adults to recount, there could be deficits in their recall. They can't remember. And also, avoidance is a big part of PTSD. And so they don't want to talk about it. And then sadly, many of those older cohorts have died because PTSD has a higher mortality rate. So the biggest one was there was no language to describe it, except for, what we were talking about, more related to combat experience. Next slide. So older adults with PTSD have unique challenges in regard to comorbid problems, polypharmacy, that is multiple medications, and some degree of cognitive decline, which could be a new illness, or sometimes it could be just normal aging. And there are a number of reasons why perhaps PTSD symptoms can increase with age. Both chronological age, we call that cohort effects of birth year groups. We talk about baby boomers, that is a cohort. Gen Zs are a cohort. Millennials are a cohort. And they have very unique features. So there's something called a cohort effect. And when we are looking at the older adults, remember I said there was no language. And they also have lower levels of mental health literacy to talk about symptoms. So chronological age and developmental processes of aging impact the experience of PTSD for older adults. Role changes and functional losses may make coping with memories of earlier trauma more challenging. Why? Because your overall stress level is up, right? You have retired, you're trying to fumble and find your way in the world now. Who am I? What's my role? You're losing your independence. Those are all stressful things. It becomes much more difficult than to manage traumatic memories. Such stressors include retirement, increased health problems, decreased sensory abilities like hearing or vision, reduced income, loss of partners or loved ones, decreased social supports because your friends are dying, maybe dementia, and other stresses which cause functional decline, which makes it more difficult for older adults then to cope with traumatic memories. To manage post-traumatic stress symptoms in early and middle life, individuals may engage in avoidance. And we're going to talk a lot about that. Avoidance-based strategies, such as maybe drinking alcohol or working 80 hours a week so you don't have time to think about your trauma. That become less available to older people, correct? If you're living in a nursing home, you don't have access to alcohol. And so those could have been their coping strategy, and suddenly that's not there. At the same time, adaptation and resilience developed over a lifetime can provide a rich reservoir of coping resources upon which to draw. So I don't want to leave that out, that older adults are also resilient, and that there are plenty of older adults who have adapted and have been able to cope with their PTSD. Next slide. Symptoms of PTSD may persist or become exacerbated due to the challenges of institutionalization, illness, and late life developmental tasks. We just talked about that. So they can persist or become worse. Having survived life-threatening events may provide a basis for enhanced resilience or facing vulnerability in the, and facing these challenges. So it's both. It could increase and exacerbate, or older adults can draw upon their lifetime of experienced wisdom and resilience to cope. Next slide. Again, I'm not going to belabor this point, but I just wanted for you all to really understand this concept of cohort effects, and that cohort differences can influence how we understand or access mental health services. If there was no language for PTSD, older adults, it wasn't in their vocabulary, it wasn't on their radar screen. And, for many older adults, passage of time has healed wounds. And so they think, look, we are fine, though they may have had lifetime experience of trauma and traumatic symptoms. Next slide. Cohort factors also explain, I've already said that, older adults may be less likely to identify problems from a psychological framework. Remember, older cohort did not grow up with mental health and mental wellness all around them. It was, in fact, considered a shameful thing to say that you need mental health help. For example, older veterans may contribute problems to more recent issues, such as the aging process, and not relate their symptoms to something that happened way 30 years ago in Vietnam or in Korea. And also, it's possible that trauma history is often overlooked in older adults because PTSD is a relatively new disorder within our diagnostic system. And so we don't even ask that of older adults, which is kind of a systemic inequity. And no, older adults don't experience that. No, they do. There was no language for it prior to 1980. Next slide. And so I'm not going to go over every slide. I said you will be getting my slide deck. Here is a list of normal changes associated with aging that can exacerbate. Remember, I said it can exacerbate or worsen traumatic stress. We talked a lot about retirement, loss of family, friends, all of that, death of a spouse, actually declining physical strength, illness, medical procedures, hospital stays. I love that increase of free time can lead to increased reflection of unpleasant and traumatic life events. Remember, one of the coping strategies when people are younger is avoidance is workaholic, where you work 60, 80, 90 hours so you don't have to think about your memories. Suddenly you have all this time. Next slide. So I know there's a lot of literature around trauma and veterans, PTSD, especially combat veterans. Memories of wartime experience can be upsetting long after completion of military service. Compared to the general population, older veterans have higher rates of both lifetime trauma exposure and PTSD symptoms due to combat and war zone related exposures. How many of you, many of you said case managers, QMHPs and managers, etc. Ask in your intake assessment, are you a veteran? What branch of the military? Did you experience combat? And then do you assess for PTSD? Or I would encourage you to even start asking more in depth about being a veteran. Among older male veterans, the prevalence of lifetime exposure is 85%. Older male veterans. That means, Vietnam, Korea, all of them. In a study of older male combat veterans and ex-POWs of World War II and Korea, the lifetime prevalence of PTSD was 53%. So very high, almost more than half of them had PTSD. Next slide. So trauma among women in the community. Although remember I showed you the slide that there's a gender difference. Women have more in that study than men experience. Although there's a growing body of research examining the effects of traumatic events more frequently experienced by women, such as rape, domestic violence, older women have been underrepresented in those studies. They're really looking more at like younger women. Among the community sample of older women, 72% had experienced at least one type of interpersonal trauma during their lifetime, whether it was childhood physical or sexual abuse, rape, or interpersonal violence of other kinds. In comparison, look at that, 72% of older women said they had experienced that. In comparison, 44 to 55% of women of all ages reported experiencing that. So older women were reporting it at much higher rates. One type of interpersonal trauma very relevant for older women is intimate partner violence. Middle-aged and older women are more likely than younger women to have experienced intimate partner violence for a longer span of time and to have remained in the violent relationship. So how important it becomes for all of you on this training today to ask about that. Because I said there is a clear gender difference. Next slide. And here it is association of stress-related disorders with subsequent neurodegenerative diseases such as dementia. Post-traumatic stress disorder has been associated with increased risk for dementia. And this was a very recent study published in JAMA Neurology, where they examined the association between stress-related disorders and risk for dementia. So absolutely, they have established that link, that it is associated with increased risk for dementia. Next slide. So when we talk about brain health, when we talk about risk reduction for dementia, brain health, it becomes very important to talk about PTSD, to encourage people to seek treatment for it, because it puts them at risk for brain dysfunction. I have several slides on TBI, traumatic brain injury and PTSD. I'm not going to go over all of them, but PTSD and TBI coexist. It's often difficult to sort out what's going on. Changes in cognition, such as memory, concentration, depression, anxiety, insomnia, fatigue, are common for both diagnoses. One basically feeds and reinforces the other, so it's a perfect storm. So it's a challenge. Next slide. And I have given you some additional slides, and because of time, I'm not going to go over them. You're going to get them. But really looking at what's the difference between TBI and PTSD, especially for all of you who work and maybe are doing assessments. And so I will let you take a look at these slides when you get my slide deck. Next slide. And there's another slide, similar one. But you can go on to the next one. Yes, so special considerations for working with older adults with trauma who are survivors. You know, you obviously have to do a good assessment on their cognitive baseline. Many of them are residing in long-term care settings where, first of all, there's little access to good mental health services, where the institution itself may be triggering. And then they're also grappling with end-of-life issues where, remember we said, when there's heightened stress, it can actually unmask and even exacerbate, you know, a long kind of dormant symptoms of PTSD. So those are some special considerations for older adults. Next slide. So what is trauma? So now that I have completed my section on, you know, on older adults and trauma, prevalence, we are now really going to dwell into really the clinical aspects of this. So what is trauma? It is experience in one in which it is overwhelming, threatening, frightening, or you feel out of control. Trauma includes being in an accident, such as I showed you a picture earlier, a road traffic accident, or maybe an accident at work with heavy equipment. Being the victim of violence, such as being physically or sexually assaulted, imprisoned, or tortured. Being in a life-threatening situation such as a war and conflict, natural disaster, or a severe health emergency. And even witnessing violence towards another person or witnessing death, as like, for example, in war zones or in terrorism. Next slide. So here are traumatic stresses: combat events, motor vehicle accidents, child abuse. Next slide. Natural disasters, sexual trauma, physical assault, whether it is intimate partner or, you know, or a stranger assaults you. Next slide. Some traumas are isolated one-off events that are unexpected and happen like out of the blue. Other traumas are frightening in a different way, that they are expected, anticipated, and dreaded. Some jobs expose you to trauma. For example, the military or EMS, you know, law enforcement and first responders. By the way, they have very high rates of PTSD, by the way, law enforcement and EMS. Because they are witnessing distressing events every day. Next slide. So what is PTSD and how is it conceptualized in the 5th version of DSM? Remember I said DSM-3 first coined the term PTSD in 1980. We are now in the 5th iteration of DSM. So the latest version has made a number of notable evidence-based revision to PTSD diagnostic criteria. which are both important conceptually and has profound clinical implications. First, because it became apparent that PTSD is not just a fear-based anxiety disorder, as the previous DSMs were stating. DSM-5 has expanded it to include dysphoric anhedonic presentation, that is loss of pleasure, which are very prominent. Such presentations are marked by negative cognitions and mood states, as well as disruptive behavior symptoms, such as impulse control problem, recklessness, self-destructive behavior. So it expanded it beyond just it being a fear-based anxiety disorder. Furthermore, as a result of research-based changes to the diagnosis, PTSD is no longer categorized as an anxiety disorder. Prior DSM-5, it used to be under anxiety disorders. PTSD is now classified in a new category called trauma and stressor-related disorders, in which the onset of every disorder has been preceded by exposure to a traumatic or otherwise adverse environmental event. This is very critical in the diagnostic criteria. And then I will go on to describe the changes. So please understand, it is no longer under the rubric of anxiety disorders. It is now under trauma and stressor-related disorders in DSM-5. Next slide. Just for our purposes, we are not going to be talking about children, PTSD in children. My presentation is for adults and older adults. And so I just wanted to put that down there, that DSM-5 introduced a preschool subtype of PTSD for children ages 6 and younger. Next slide. So here are the criteria that you have to meet. The stressor criteria, which is very important, that the person has been exposed to a catastrophic event, including actual or threatened death or injury, or threat to the physical integrity of him or herself or others. It could be repeated, indirect, one time, whatever, but that is a must. Criteria 2 is intrusive recollection, and we are going to go over them. Category 3 is avoidance. Next slide. Category 4 is negative cognitions and mood. That means negative thinking patterns and kind of that anhedonic dysphoric mood. And E is alterations in arousal or reactivity. And so those are now the 5 criteria that we all use to make a diagnosis of PTSD, with A being absolutely critical. Next slide. So I'm very quickly going to go over the criteria. Criterion A is stressor, which is required. A person has been exposed, direct exposure, witnessing it, learning that a relative or close friend has been exposed, indirect exposure, all of that would qualify for A. B is intrusive symptoms. One of them is required. So one of the bulleted points is required. The traumatic event is persistently re-experienced in the following ways: unwanted upsetting memories, nightmares, flashbacks, emotional distress after exposure, physical reactivity after exposure to traumatic reminder. So you have to have one of that. Next. Here is intrusion. That is criterion B. Distressing memories, nightmares, flashbacks, intense psychological distress when you think about it, and physiological reaction, which is kind of you're re-experiencing the trauma over and over again. So you have to have one of this to qualify for the diagnosis. Next slide. C is avoidance. Again, one of these, avoidance of trauma-related stimuli after the trauma, such as trauma-related thoughts or feelings or trauma-related external reminders. So you're avoiding them. You have to have one of that. And then D is negative alterations in your thinking pattern and your mood, and you have to have two of these. Inability to recall key features of the trauma, overly negative thoughts and assumptions about oneself and the world, exaggerated blame of self and others for causing the trauma, negative affect, decreased interest in activities, feeling isolated, difficulty experiencing positive mood. You have to have two of this from criterion D. Next slide. Again, I'm giving you the criteria for C, which is avoidance. Avoid thinking or talking about your traumatic memories. You avoid external reminders. Inability to remember important parts of the trauma, so you have gaps in your knowledge. Inability to experience positive emotions. That's what avoidance is. Next slide. And remember the cognition and mood, persistent, distorted blame of self and others. Why did I survive? I am bad. That's why this happened to me. Why did I not stand up and do something? Or negative emotional states, constant dysphoria and low levels of depression and anhedonia. So that's the emotional state. Next slide. Diminished interest, detachment and estrangement from others, and negative beliefs and expectations. Negative beliefs about yourself and about the world being a safe place. And expectation that something bad will happen if I were to think about it. Next slide. And then we have E, which is alterations in arousal and reactivity. You have to have one. Irritability or aggression, risky or destructive behavior, hypervigilance, heightened startled reaction, difficulty concentration, difficulty sleeping. And then you have criterion H, which is duration, that the symptoms have to be more than 1 month. A G is functional significance, that these symptoms are causing a great deal of distress, leading to functional impairment. That means you can't hold a job, you can't attend school, functional impairment. And a criterion H is exclusion. Symptoms are not due to some other, to substance use or some other illness. So this is the new DSM-5 criteria for PTSD, which is kind of very different from DSM-4. Next slide. So arousal and reactivity, because we're going to talk a lot about it. Angry outbursts, irritable behavior, reckless self-destructive behavior, hypervigilance, you're always on high alert, exaggerated startled response, which is all reactivity. Next slide. Problems with concentration, when you're hypervigilant, when you're always on edge, it's difficult for you to concentrate, correct? And it also disturbs your sleep. Next slide. And then you have two specifications. Again, you talk about dissociative specification and delayed specification, which is really, we are looking at depersonalization and derealization. And then delayed specification is where you have not met like the full criteria for 6 months or so. Next slide. So I just wanted to set the stage with, what is DSM-5 criteria. So what are the 3 E's of trauma? The 3 E's are event, experience, and the effect of that event and experience on you. Event can include an actual or extreme threat of harm. We've talked about, any of those adverse childhood experiences or war or, car accidents. They can happen one time, or they can happen repeatedly over time, or they can happen throughout your lifetime. Experience is how the individual experience of that event determines if it is a traumatic event for you. Factors include how the individual assigns meaning to it, how the individual is disrupted physically and psychologically by that event, the individual's feeling of powerlessness in that event can trigger feelings of, say, humiliation, shame, guilt, betrayal, cultural beliefs, and availability of social supports. Age and developmental stage of the individual when that event happened. You know, were you a child or were you a 26-year-old soldier in Vietnam? Next slide. And the effect, how do these adverse, how these events affect you in terms of maybe your inability to cope with normal stresses, inability to trust and benefit from relationships, cognitive difficulties with memory, attention, thinking, self-regulation, controlling your expressions of emotion. That means you're highly dysregulated emotionally. So those are the three E's of trauma. Next slide. So what causes PTSD? The main cause of PTSD and complex PTSD is being exposed to a traumatic event. I said that is absolutely needed. Not everybody, however, who experiences trauma goes on to have PTSD. That's important too. Next slide. It is normal to be affected by traumatic experiences. If you have been through a trauma, you might feel shocked, scared, guilty, ashamed, mad, vulnerable, numb. With time, most people recover from it. Remember, I said it's an extinction. It gets extinct. They recover from the experience and find a way to live with them. In fact, there's a whole burgeoning area of research and scholarship called post-traumatic growth, that people actually grow as human beings. However, there is a group of people that the effects of trauma last for much longer and may develop into post-traumatic stress disorder. Next slide. So what's the difference between stress and traumatic stress? We all react to some external stimuli with stress response, ranging from physical to emotional and to cognitive and behavioral. Traumatic stress refers to emotional, cognitive, behavioral, and psychological experience of individuals who are exposed to or who witness events that overwhelm their coping and problem-solving abilities. In other words, trauma, which produces traumatic stress, occurs when our coping mechanisms are overwhelmed by outside events. That means we can no longer use our normal coping mechanisms to deal with that traumatic event. There's an imbalance. Next slide. And so why do some people develop it? Here are risk factors and resilience factors for why some do and some don't. Here are the risk factors: exposure to previous traumatic experiences, particularly during childhood, getting hurt or seeing people hurt or killed, feeling horror, helplessness, or extreme fear during that traumatic event, having little or no social support, dealing with stressors after the event, such as the loss of a loved one, pain, injury, or loss of a job, having a personal history or family history of mental illness or substance abuse. Those are all risk factors. Here are some resilience or protective factors: seeking out and receiving support from family and friends. Could be faith community, could be colleagues at work. Learning to feel okay with one's reaction and response to the traumatic event. You know, this is okay, it's normal to feel this way. Having a coping strategy for getting through and learning from the event. Remember, I talked about post-traumatic growth. And being prepared and able to respond to upsetting events when they occur, despite feeling fear. So those are resilience or protective factors. Next slide. And so I'm just giving you, I'm a big proponent of psychoeducation. So I'm giving you lots of slides that you can easily pull out and use as psychoeducation with your clients. Here is a good one, for what is it like to feel PTSD? You can see constantly on guard, nightmares, feeling numb, avoiding situations that remind you of trauma. All of this is, good for you to use in any kind of psychoeducation intervention, which is, by the way, a valid best practice. Next slide. So what is at the core of PTSD? A sense of threat. When something dangerous happens to you, it's normal and actually helpful to feel a sense of threat, because you'll do something to protect yourself, because it focuses your attention on trying to be safe. The puzzle of PTSD is that people continue to feel that they're under threat, even after the danger has passed. And this is very intense and frightening. I have flashbacks where it feels like the trauma is happening all over again. I keep feeling I'm going to see that person who attacked me again. I can't sleep more than 2 hours because I'm so afraid. So at the core of PTSD is the sense of threat to ourselves. Next slide. And again, I'm giving you this for psychoeducation. PTSD can develop after trauma when you re-experience memories and feelings, a heightened sense of threat, avoidance of reminders, and changes in your beliefs about yourself and the world. And this handout basically captures what PTSD is. And I would highly recommend that you use it for psychoeducation. Next slide. And so again, one of the best interventions is psychoeducation for your clients. Talk about, what does PTSD do to your brain? And I begin by talking about the amygdala. And by the way, I talk about the amygdala even in anxiety disorders. Amygdala is part of our threat system. It's in the brain, deep in the brain. It's just pea-sized, small. If you can see that little yellow, it's no bigger than a pea. Its job is to keep us safe by alerting us to danger. It does this by setting off an alarm in our body by triggering our flight and flight response, which is our stress response, to get ready to act. Unfortunately, it's not very good at discriminating real danger out there or dangers that we are just thinking about, because it responds in the same way whether there's an actual lion walking towards you or you're just thinking about a lion walking towards you. It will react in the same way. This means that it sets the alarm off when we are thinking about an unpleasant memory from the past, even though the danger has passed and you are in full stress mode. Then there is the hippocampus, which is right next to the amygdala. This helps us store and remember information. So it's like our memory bank. It's like a librarian. And it tags our memories with information about where and when they occurred. When our threat system is active, the hippocampus doesn't work so well. It can forget to tag memories with time and place information, which means that sometimes they get stored in the wrong place. And when we remember them, it feels like they're happening all over again. So these are the two main parts of your brain which are involved in PTSD. So even beginning to explain this to a client who has severe symptoms will make a lot of sense to them. Next slide. So here are the symptoms of PTSD in a nutshell. Remember, at the core, it's a threat to self, a sense of threat. Hyperarousal and hypervigilance. negative thoughts and moods, re-experiencing over and over again what happened, avoidance of reminders. I won't drive a car because I'm too afraid it reminds me of my accident. I won't go out at night because that's when I got assaulted and mugged. I don't like the smell of coffee because that's when that man, hit me on my head outside the coffee shop. The coffee reminds me of those triggers. So I'm just going to avoid it. Next slide. And then here again, intrusive, avoidance, heightened arousal, change in thoughts and feelings. So I'm giving you all of these so that you can actually use them right away with your clients as part of psychoeducation. Next slide. So I'm going to talk a little bit about the symptoms. What does re-experiencing actually look like? That essentially means that the memories of the event play over and over and over again. And they come in the form of like flashbacks during the daytime and as nightmares at night. These are very real flashbacks and nightmares. And they can be re-experienced with any of the senses. Like
Nirmala?
Yes?
Quick break. We're halfway through, just so you know.
Okay, thank you. Yeah. So any of the senses, and they are very intrusive. You can have nightmares about the events. You can feel physical reactions in your body when you're reminded. I knew a client who used to actually throw up. She had such extreme nausea every time she even thought about it. And then there's this numbness, dissociation connected from the present moment. Next slide. Arousal. Always on edge, on guard, following a trauma. You may find it very difficult to relax. Or you may not be able to sleep. Because what? You're always on guard. My gosh, the intruder is going to come in. My rapist is still out there. He may come in. Or imagine if you're a young child being molested in your home, sexually molested in your home by someone you trust. Always on edge, always on guard. Always looking out for danger. This is what we call hypervigilance. Feeling on edge so that you're easily startled. Every time you hear a noise, you jump. Having difficulty falling asleep. You can't concentrate. How can you concentrate when you're constantly feeling unsafe, correct? Next slide. And then there is avoidance. This is a cluster of symptoms, like arousal we talked about and reliving memories. A normal human way of dealing with physical or emotional pain is to avoid it or to distract yourself, correct? I'll just distract myself. When you have PTSD, you may try to avoid people, places, or any reminder of that trauma. You may try very hard to distract yourself in order to avoid thinking about what happened. Avoiding reminders of trauma, trying not to talk or think about them, and feeling numb, like you have no feelings. This is a coping mechanism that people with trauma develop, which is avoidance symptoms. There is some short-term gain, but not any benefit long-term in avoidance. Next slide. Then you have negative thoughts and moods, which is now the new criteria. Trauma has a powerful effect on how we think. That should be no surprise, right? Many people blame themselves for what happened. I just recently saw a movie about these 4 Navy SEALs, in Afghanistan war, and how only one of them came back, 3 were killed. And the amount of guilt and shame he expressed. I mean, he's gone on to have full-blown, suicide attempts and PTSD, but blame. Why did I survive? Why could I not save them? It was my fault. Or maybe you replay parts of the trauma and think, what if? Or if only I had not worn that top, or if only I had been better to my dad, he wouldn't have, molested me. Thinking negatively about yourself, feeling guilty or ashamed, feeling depressed, feeling that no one can be trusted. Now, can you imagine how it affects your mood? If that's your view of yourself in the world, that nobody can be trusted. Next slide. So I want to talk about the effects of PTSD, what goes through your mind, how you might feel and how you might act. We talked about intrusive and unwanted memories. There could be images in your mind about what happened. Thoughts of trauma is happening right now again. Thoughts that, hey, it's my fault that it happened. And some people have thoughts that, hey, I'm going mad. I can't control it. I'm just going mad. And then you relive the emotions you felt. Fear, anger, humiliation, disgust, shame, dissociation, all of that. And then you avoid places and people that remind you of the trauma. This is a nice fact. This is a nice slide to just copy and give to your clients. This is what PTSD is. This is how it affects your life. Next slide. Again, I'm just giving you tools that you can use, whether in a group setting or individually. This basically covers DSM-5 criteria for PTSD. Next slide. So what is complex PTSD? I included this because I've been asked that many times. People who experienced layer after layer, experience after experience of trauma. Child sexual abuse, human trafficking, where there is little chance for escape, have experienced trauma early in their lives, or have experienced trauma as a result of things that were done by their parents or caregivers, often have extra symptoms in addition to just the regular symptoms of PTSD, which are already bad. When people experience these symptoms as well as PTSD, mental health professional might label it as complex PTSD. And I was reading this article, it was sometimes referring to it as PTSD plus. Research indicates that many of the treatments that are effective for PTSD are also quite effective for complex PTSD. Okay, next slide. And here I'm just giving you like a breakdown of what is complex PTSD, how much trauma a person experienced, like a bigger dose of it, the type of trauma, when it happened in a person's life. Remember I said developmental, severe problems in managing emotions, strong beliefs about yourself as defeated, worthless, diminished, failure, and difficulties in sustaining and feeling close to anyone, like having close relationships. Next slide. And so here I'm just giving you again that Venn diagram. You will be getting this where you can see the commonalities are in the intersection of the two circles, but they are still quite distinct, in terms of just PTSD and complex PTSD. Next slide. So what keeps it going? We have veterans from Vietnam experiencing severe PTSD. Did you know unprocessed memories? Memories that pop up are vivid and emotionally powerful, feel like it is happening today. Unhelpful beliefs about the trauma. Feeling the danger is present now, today. You blame yourself. You have guilt about it. You think you're going mad with these symptoms. And then that avoidance and safety strategies. I will just avoid those situations that make me uncomfortable, ashamed, or fearful. I just will not deal with them. I won't go there. That's what keeps it going. And that's where our interventions are. Next slide. Look at unprocessed memories. The memories are sometimes so strong that I can smell my attacker's aftershave. It feels like I'm there again. My partner and children notice me zone out. I feel so frightened when I have a flashback. Sometimes I worry that I'm losing my mind. Next slide. Beliefs about your trauma and its consequences. For a long time, I believed that what happened was my fault and I carried a lot of guilt. Until I got the right treatment, I believed that the problem was that I was weak. I was at fault. There was something wrong with me. The person who hurt me wanted me to believe that I was powerless and worthless. Next slide. So coping strategies include avoidance. I love this. You know, he was a very maverick, by the way, psychiatrist, R.D. Laing. Pain in this life is not avoidable. But the pain we create, avoiding pain is avoidable. Avoidance, again, I said, is natural. It is protective. When we experience something like upsetting. But people with PTSD tend to avoid things such as their memories of the trauma, which stay unprocessed. Avoid reminders. They use alcohol and other drugs to numb the pain, so they don't have to think or talk about it. Unfortunately, avoidance has some unhelpful effects on PTSD. Although I said in the short term, it gives you some stress relief, but in the long term, your memories and your beliefs remain unprocessed. Next slide. What does it feel to have PTSD? You're constantly on edge and you're looking out for danger. You're constantly on guard, watchful and easily startled. Can you imagine the stress hormones surging through your body to be constantly on guard and watchful? You experience strong unwanted memories of the trauma. So much so that you feel that it's happening right now, all over again. You feel numb and detached from people. And you feel guilty or unable to stop blaming yourself or others for the event. Especially if you're not processing those thoughts and feelings. Next slide. So how does it affect your clients? Or it may have affected you, any of you who are participating in this training today. We already talked about feeling scared, looking out for danger, avoiding places, people, thoughts, memories as a way of avoiding danger. Having these flashbacks pop into your head. And these could be sights, smells, sounds, tastes, any of that. Feeling on your body. And then having these really bad nightmares every night where you can't sleep. That's the lived experience. Next slide. You have problems with concentration. You feel angry. There's sadness and depression. You have great difficulty trusting people, especially when you have complex PTSD and where you were perhaps experienced trauma at a developmentally younger age with someone you trusted. And then there's that numbness and dissociation. Next slide. So here are the screening instruments. I don't know whether you all use it. So one is called the Primary Care PTSD Screen, which basically follows the DSM-5 criteria. That is administered by the clinician. And then there's one which is a self-report. And I have sent both of them to Angela Jensen and Angela Franklin, to send to you with the supporting, with the PowerPoint presentation. I would highly recommend you take a look at them. These are validated screening tools. Many of them developed at the Veterans Administration. Next slide. And the good news is that these tools have been, these trauma and PTSD assessment measures have been used validly with older adults, both of them. So they are very valid to use with older adults too. Next slide. So what are the goals for treatment? Treating distressing symptoms. Reducing those avoidant behaviors. I'm not going to think about it. I'm not going to go there. I'm not going to drive a car. Treating comorbid conditions. I already talked about the high prevalence of depression, substance use, anxiety. Improving adaptive functioning, which includes restoring a sense of safety and trust. Remember, I said at the core, PTSD is a diagnosis of a threat to self, feeling unsafe. So restoring that safety and trust. Next slide, please. Here is I love this functional analysis. And by the way, I use it not just for PTSD, it can be used for depression too. Ineffective behavior being reinforced. Okay, I won't think about these memories because I'm going to avoid that situation. Life is not currently full of valued things. And your effective behavior is weakened. That means your coping behavior is weakened. That is essentially the functional analysis of PTSD. Next slide. So what are the treatments for PTSD? Cognitive behavioral therapy, especially trauma-focused CBT, EMDR, eye movement desensitization and reprocessing, cognitive processing therapy, CPT, prolonged exposure, narrative exposure therapy. They all contain some core common elements. Work to change the meaning of your experience, expose you to those very memories that you're trying to avoid, and reduce unhelpful coping strategy by replacing them with more resilience and more resilient coping strategies. So all of these various evidence-based modalities, that is what they do at their core. Next slide. And I'm going to do very quick. I'm not going to go over each and every one of them, but CBT is perhaps one of the most preferred treatments for PTSD. There's extensive evidence. A trauma-focused CBT in particular addresses memory, thoughts, feelings related to that traumatic event. The client is requested to focus and confront the traumatic experience in a session by thinking about the trauma in great detail, which is the opposite of what they've been trying to do all their life, right? Avoid it. This helps to identify unhelpful thinking patterns and distortions and replace them with realistic thoughts. And it also increases the ability to cope by reducing escape and avoidance behavior. So it's trauma-informed CBT. Next slide. I really like cognitive processing therapy. It really makes a lot of sense to me. Is one kind of cognitive behavioral therapy. It is very prescribed 12 sessions. CPT teaches you how to evaluate and change the upsetting thoughts you've had since your trauma. By changing your thoughts, you can then change how you feel. You have to do some writing in this kind of therapy. Over the sessions, you actually write down, so that it's processing therapy, and how by writing and reframing, it lessens the intensity of your symptoms. And these are, by the way, all evidence-based, tested rigorously. Next slide. Prolonged exposure. This is also quite popular in the VA. It teaches individuals to approach their traumatic-related memories, feelings, and situations. Clients learn that trauma-related memories and cues are not dangerous and should not be avoided. So in this session, in prolonged exposure, effectively addresses PTSD by targeting two aspects: avoidance and promoting emotional processing. So what do they do? It's called imaginal exposure. So it's done in therapy sessions where you are actually reviving images of your trauma. That is what is imaginal exposure. And that's how you confront the trauma mentally. And then there is in vivo exposure, where they confront safe reminders of the trauma in real life scenarios. So real life scenarios are given to them, and then they kind of reprocess it through this exposure technique. Next slide. So I really want to again emphasize how important this therapy is. It addresses avoidance by promoting emotional processing of trauma memories. And it involves changing the fear structure in the patient's memory, with the focus on changing the narrative around feared stimuli responses and their meaning by doing those two kinds of exposures that I just talked about, in vivo and imaginal. Next slide. I've given you more information on exposure. In exposure therapy, the bottom line is it aims to rewrite the fear structure and correct information based on these experiences. You have this distorted information in your head, which you've carried for years. Through this therapy, we are trying to rewrite the narrative. Next slide. Similar to narrative exposure, it's similar. The focus is on imaginary trauma exposure and reorganizing your memories. Basically, you're rewriting the narrative about your trauma. Next slide. It's a lot of work. I mean, it sounds simple in one slide. Many of you have heard of EMDR. It was really developed by the psychologist, Shapiro in '95. It focuses on how on the memory and how it is stored, reducing and eliminating problematic symptoms. The therapy incorporates the use of eye movements and other forms of rhythmic left-right stimulation, such as tones or taps. When the clients focus on the trauma history and simultaneously experience bilateral stimulation, the vividness of the emotion is reduced. That is what EMDR is. Next slide. And here are the recommendations. APA, through a consensus. Psychotherapy strength of recommendation for adult patients with PTSD strongly represents that clinicians offer one of the following psychotherapies. And they're not given in order, they're just listed alphabetically: cognitive behavioral therapy, cognitive processing therapy, cognitive therapy, and prolonged exposure therapy. As you can see, EMDR is not in the top 4. Next slide. For older adults, what should you consider? The presence of cognitive decline may impact memory, learning, attention, and concentration. So really doing a good assessment of, do they have the cognitive ability to really engage in therapy? Beyond modifying treatment, administration, and seeking consultation, it is also best practice to engage caregivers, whether formal or informal, because they can actually give a lot of support to the older adult who is in therapy. Next slide. Again, individuals' cognitive abilities should always be considered. In cognitively intact older adults with PTSD, interventions can be similar, including psychoeducation. Can you please excuse me?
Maybe what we can do is actually take a 5-minute bathroom break. So at 10:35, so that's 5 minutes from now, we will return. So we'll give everyone a bio break if you want to take advantage of that.
Thank you. I just lost my voice. I need to drink something to get it back. Thank you.
Yeah, so 10:35, we'll be back.
I appreciate that. Suddenly, I just couldn't talk. Oh, I'm better now. I have my coffee. I suddenly lost my voice. Hello, everyone. Angela, just let me know when we are going to start.
Okay.
Thank you for that. Thank you for that break. I suddenly lost my voice. Because and then I realized I've been talking since 7:30 this morning. So my apologies. I had a cup of coffee waiting outside. My voice is much better now. Thank you. Thank you for that break. Shall we just get back to training? Okay. So I was at this slide on, what are some considerations? I mean, what are some interventions for older adults? They are the same as younger people, psychoeducation, relaxation training, development of coping skills, and any of those evidence-based clinical modalities I showed you earlier, which are cognitive and behavioral therapy. So they are absolutely applicable for older adults too. Next slide. And this, and you will be getting a link to this, which I sent to Angela. This is more about organizational uptake. in mostly in long-term care settings like nursing homes, assisted living, where a lot of older adults live. It's called person-centered trauma-informed care, PCTI, which is a holistic approach to service provision that promotes the dignity, strength, and empowerment of individuals with a history of trauma by incorporating knowledge about the role of trauma into agency programs, policy, and procedures. So I would absolutely encourage all of you who work, in training, the workforce to really disseminate this information in long-term care settings. And you will be getting the link to the entire PCTI. So next slide. So what can you do? And I know we have a very broad swath of people attending. Some of you all are clinicians, some of you were peers, and all kinds of other roles. Aside from all the evidence base that we talked about, the next set of things anyone can use. Let them know you care about them. Let them know that you're willing to listen if they want to talk. Don't judge them for the ways they are reacting. Don't force them to speak if they don't want to, and get them help with basic needs, which is like very basic. Next slide. Assure the client that they are not to blame. And this is, anyone can do this. You don't have to be a QMHP or a psychologist or a licensed clinical social worker. Clients who have gone through trauma may be experiencing PTSD. They blame themselves, and they maybe have guilt, especially survivor guilt and blame. So really assure the client they're not to blame. Do not avoid talking about the trauma for fear of re-traumatizing, because that's exactly what they've been doing for years and have these unprocessed memories. And then offer psychoeducation. And that's why I gave you so many slides, which can be really taken, just those slides taken out and develop psychoeducation for clients. Psychoeducation is often described as psychological first aid, and I absolutely buy that. Actually, just understanding what your brain is doing sometimes can be such a relief. Next slide. Offer compassion. You're already feeling bad, so there's no point in you making things worse by criticizing yourself. Try offering kindness to yourself. Be understanding. It's no wonder you're feeling frightened, because you've just had unwanted memories of the past. You're safe here. Be kind. What would you say and how would you act towards someone else who was suffering like you are? Next slide. You will be getting stuff on grounding, like standalone documents, which I've sent. But many of you may be familiar with grounding techniques, especially for people who often get dissociated, when they're overwhelmed, with traumatic memories and flashbacks. And this is one way to introduce grounding. I'm not going to go over it. But you'll be getting the actual script and all of that. Next slide. Here is the actual grounding exercise of the 5 senses, which is essentially bringing the person back to the present. Correct? What are anxiety? What are stress disorders of all kinds? You're focusing on what happened in the past, or you're worried about it happening again. So these grounding senses actually bring you to the present, bring you back to the moment. But what I like is how they have applied grounding. If you can move to the next slide. Okay, no, one more, please. So I've given you lots of information on grounding techniques, the rationale, why it's good, and I will let you all read it. But there's one more slide. There's one thing that I really like, which I have used this a lot: grounding statements. Unwanted memories in PTSD can make us mentally time travel back to the trauma, correct? And we sometimes forget that we are in a safe place in the present. It can be helpful to write a grounding statement to remind yourself that you are safe. You can then carry it with you and read it when you get upset or having a flashback. Useful statements talk about safety or remind you of what is different now compared to when you experience the trauma. For example, it is 2020 and I am safe. My trauma happened a long time ago and I survived. My trauma happened in the past and I'm only remembering it now. The memories upset me, but they are just memories. They cannot hurt me again. I'm safe in the present moment. I know I have survived because I'm bigger and older than I was in my trauma memory. I have my own family now and I know I'm loved. And when I was doing my group, it was more broadly an anxiety group, but it involved PTSD also. We would, one of the exercises was writing grounding statements. And this is, anyone can do this with clients. Next slide. I love this skill. It is out of DBT. I don't know how many of you are DBT trained. It's called the improve skill. I use it. I call it trans-diagnostic use. It's not, it can be used for anyone with depression, with PTSD, with borderline. So it's the improve skill, and improve is a acronym which stands for imagery, meaning, prayer, relaxation, vacation, encouragement. Meaning is improve the moment with meaning. Find purpose or meaning in your daily activities, in your everyday activities. One is improve the moment with one thing in the moment. Focus your attention on it. Where grounding becomes really important. I love vacation. Improve the moment with vacation. Go to the beach. I mean, in your head, you're going on a vacation. And encouragement, to improve yourself with encouragement to yourself in the present moment. Maybe I used to actually give a list of affirmations, that people could pick. I actually still have it. I have a box of affirmation, which I bought like commercially. Beautiful cards with, pictures on it, and people could take one. And it had an affirmation on it. And that would be something that they would carry as encouragement to themselves. And this skill comes out of distress tolerance, DPT. Next slide. Here I'm just giving you like a one pager that you can use with clients, like what is the improved skill. By the way, I know Angela Franklin is very interested in end of life. I use this improved skill with people with serious illness, who are at the end of life and are feeling, a lot of stress and fear and agitation. We teach them the improved skill. Next slide. Create meaning. How many of you have read the book Man's Search for Meaning, Viktor Frankl? If you haven't, I would highly encourage you. He found meaning in his, he's a Holocaust survivor. He found meaning in being in Auschwitz. So how do you create meaning? And I wish I had time to go over every skill of the improve, but this is one of my favorite ones, but I'm going to let you take a look at it. Helping your client create meaning, from their experience. Next slide. Improve the moment. This is a worksheet for them to create that meaning, that the M in improve. What do you believe about suffering? Is there a purpose? What have you learned through your suffering, which would be your trauma event, Have you ended a toxic relationship or gotten closer to one? What inspires you? What or whom do you live for? How can you bring this inspiration into your daily life? So this is a nice worksheet to help people create meaning, which is the M in improve. Next slide. Encouragement. Remember, I said I used to give out affirmations. They could pick one from a box. So one form is self-encouragement and rethinking the situation where you're cheerleading yourself. Whether it is you go girl, I will make it out of this. I'm doing the very best I can. I used to teach one was this too shall pass, which is, if you're having overwhelming feeling, this will pass. And you even repeat it. I can stand it. This too will pass. It'll be okay. It won't last forever. These are like self-encouragement and you're cheerleading yourself. And by the way, these are all tested and, this is all out of DBT. So next slide. The next set of skills are also DBT. They are the accept skills. I don't know. I just love DBT. I've used it a lot. So I don't know how many of you use DBT, but accept is, it's again an acronym: activities, contribution, comparison, emotions, pushing away thoughts, sensations. And so this is another skill to teach. Anyone can do it, whether you're a peer, you can teach it, whether you are a volunteer, you can teach it, or you're a QMHP, you can teach it. You don't have to be like a licensed person to teach this skill. Next slide. You need to understand it, And so these are both coming out of the distress tolerance modules of DBT. And I'm just giving you, the comparison with both. I highly recommend using these both with your clients with trauma. Next slide. There is pharmacotherapy also exists. There are two main groups of symptoms we've talked about. The first group consists of core PTSD symptoms. And the second group is secondary symptoms, which are impaired functioning, poor coping skills, all of those psychiatric comorbidities we talked about. Next slide. And here are what APA recommends. Medications conditionally recommended for the treatment of PTSD are Zoloft, Paxil, Prozac. Obviously, each patient varies in their response, but this comes straight out of the APA clinical practice guidelines, medications. Next slide. And then there's specifically medications for nightmares. Prazosin, which is, I think, if I'm not mistaken, it is a blood pressure medication, was the most frequently prescribed nightmare medication in the VA for PTSD. And then I have clients who've been on both clonidine, did not achieve full PTSD nightmare recall cessation, but they use both those medications. And then there's antipsychotics, were the most frequently prescribed class of medications at the VA for PTSD nightmare treatment. Though all three are prescribed for nightmares in particular, all three of these medication types. Next slide. If you work in primary care, I would say anywhere, really. Encourage trauma-focused psychotherapy. Explain that untreated PTSD can negatively impact your health and enjoyment of life. Point out that no treatment symptoms are likely to get better and they may just get worse. Acknowledge there are many treatments for PTSD, but research shows that some treatments work better than others. Be a myth buster. Trauma-focused therapy for PTSD is not lying on a couch, talking about. It's very much skill-based. Explore why they are declining your referral to really work on their trauma symptoms. And acknowledge that there are, that medications are always an option, but there are side effects and they are conditionally recommended. That means they say talk therapy is very important in PTSD treatment. Next slide. A word about trauma-informed care. Are you all, I think 90% of you said you'll work for a trauma-informed a trauma-informed care organization, where we have shifted the focus from what's wrong with you to what happened to you. So it is an approach to care that acknowledges that healthcare organization and care teams need to have a complete picture of patient's life situation in order to provide effective healthcare services with a healing orientation, where we do not re-traumatize patients, clients, and consumers. Next slide. Trauma-informed care seeks to realize the widespread impact of trauma. Remember, I said 90% of older adults have experienced trauma. Recognize the signs and symptoms of trauma, integrate knowledge about trauma into policies, procedures, practices, and programs, and actively avoid re-traumatization. Are you, looking at this definition, are you a trauma-informed care organization? Next slide. Here is a checklist for long-term care facilities who want to become trauma-informed. And by the way, now CMS has mandated that nursing homes are trauma-informed. I'm not going to go over every one of them, but many of the OABHI specialists work with nursing homes. This may be of importance to you to take a look at if you're working with your local long-term care facilities. Next slide. Now, this is the fun part. I've given you a bunch of resources to use, which are all free. Did you know the PTSD Coach is an app which is free for you to download and use with your clients, and you can even have your clients download them, and it's available in Spanish. Developed by the VA. So these are all vetted resources. They're not some voodoo fly-by-night kind of resources. Next slide. This one too, Mindfulness Coach. Again, free to download, easy to use, both for you as a therapist and for your client. Next slide. This is a free booklet, Understanding PTSD and PTSD Treatment. You can order it in bulk, and it comes also in Spanish. Next slide. Here, I put it in for you all to use with your psychoeducation, the different kind of stress responses. Next slide. Casebook. This is, again, the APA practice guidelines that I referred to. Next slide. Here is a very good video training from the VA with the link. Next slide. Again, this is resources free from NIH, also in Spanish. Next slide. This is the APA's practice guideline. You remember I talked about the 4 evidence-based practices. If you want to know more about the guidelines, please look this resource up. Next slide. I love this. If you change the way you look at things, the things you look at change. Next slide. So I would love to hear from you in chat. What is one thing you learned today, and what is one thing you're going to change and do differently? I think, Angela, we use the older PowerPoint because it's missing my relaxation and a progressive relaxation intervention. So be sure when you're sending it out to send the other PowerPoint. Because I had put a lot of stuff on progressive muscle relaxation and relaxation as an intervention. So thank you all. I'd love to hear, what did you learn today? What is one thing that you're going to take back with you? And what is one thing perhaps that you're going to change in your practice? And Angela, if you don't mind just removing this, I'd love to see people. And we have, I think, 8 minutes.
Great presentation, Nirmala. Thank you. We do have a couple of questions. And so while folks are putting their thoughts into the chat, let's address a couple of questions while we still have you here. So from Jamila Mooney, manager of the older adult team at Coos Health and Wellness in Coos County, she makes the statement, there's a thin veil between disassociation and psychosis. So what are your thoughts? And Jamila, if I didn't capture all that, feel free to jump in there.
You know, what you just is how do you do the differential? You know, when do you know it is dissociation versus psychosis, correct? And by the way, in one of my earlier slides, I said that psychosis is very comorbid with PTSD, by the way. I think I said like 45%, of people with PTSD also have psychosis. I really think it is contextualizing the experience of having very good, thorough history, so part of your history is trauma history. And so if they are experiencing dissociation, and numbness kind of a manifestation, and you have taken a thorough history, that would key would be the history and the context of that presenting symptoms. Depersonalization and dissociation is also part of borderline personality disorder. And I've given you a Venn diagram where I showed you, what's common, what's in the intersection and what's not. And borderline personality disorder is really on the border of psychosis and not psychosis. So it's a very good question. And, partly it really comes from skill and practice. How do you differentiate? But my thing would have been, to have a very thorough contextual history of presentation of the symptoms. And from all the years that I've practiced, more often than not, it was a PTSD symptom.
So that kind of segues into, when you mentioned skill level, Casey of the OHRA, lead shelter navigator, has made the statement that approaches specific to veterans for opening conversations would be helpful. How do you actually get into doing more screening?
I gave one of my slides was on how to begin a conversation in primary care, something like that. Let me, I have my other screen here. So that could very well be also used, for starting a conversation. I'm trying to find where that slide is. It said something about how to begin a conversation in primary care. First of all, with the veterans population, what we need to be aware is there's a very strong interplay of culture, which is both the military culture and the mainstream male, culture, how men are socialized culturally to not talk about, emotional problems. So one is, that's already difficult, because military culture, you don't ask for help. It's considered, as like a flaw to ask. And that's why, there are such high rates of, behavioral health needs in veterans currently. How do we change that culture? But I get what the question is. I'm trying to find that slide where I have a slide here where I talk about how can you begin the conversation about that in primary care, but it can be used in like any setting. I will have to find that and send that particularly to maybe Angela, if you can note who asked that question, that you can then send that particular, I will send you that slide separately.
Everybody will get the slide set. And I think the takeaway is,
I'll isolate that slide and send it to you as conversation starters,
Okay. So the takeaway is not to be afraid of starting conversations about traumas with vets.
Because remember, what is maintaining PTSD is unprocessed memories and avoidance. That means we don't talk about it. My gosh, right. we're stepping on always on eggshells. That is actually perpetuating it and entrenching the symptoms. And therapy just does the opposite. It exposes you to it.
So that segues us into the request, if you can recall the name of the author of the book you referenced.
Viktor Frankl.
Viktor Frankl.
Victor with a K
All righty.
And
And
Frank,
on
RANK,
that,
called Man's Search for Meaning.
and on that note, folks, we need to wrap things up. There's always more info than we have time and more interest and diving deeper. Nirmala always just gives us a bit of a teaser, enough to make us want more. She always leaves us wanting more. So here we go. If you want more of Nirmala, we've got more of Nirmala coming up at the end of the month with our mental health advanced directives, which are very specific, as the term implies, mental health advanced directives. So it focuses on that aspect of the being, mental health. Coming up on another Thursday, June 27th, 9 to 11, and she'll be presenting in conjunction with Dr. Andrea Avila. You don't want to miss that one. So our normal spiel is, do not panic if you don't hear from us in a couple of weeks. It takes time to get everything out to you. You will get the slide deck. You will also receive a PSU survey. And if you want CEUs, a survey from NASW that you will then return to whoever generated that, whoever on the team is doing that, Janine or Lulhati. So give it a couple of weeks at least for us to gather everything, because we want to make sure that we're not bombarding you with multiple emails. We want you to get everything at one time. So look for all the attachments, everything that Nirmala referenced, your surveys, get those back to us ASAP so we can get them in the pipeline and you can get your certificates. All righty. I believe we've done it. It is 11 a.m. If you have any more questions, send out an email to one of your two Angelas, Angela Franklin, myself, Angela Jensen. We'll help you with processes. We'll help you with materials. We'll help you if you're stuck. And